Thank you very much. I have always emotional point of view to Vadodara because I did my 12th from Vadodara. So my adolescence is from here, but currently I'm practicing in Ahmedabad. I am a structural heart disease specialist who fix the structural defects of the heart, and the most bulk of my work is transcatheter aortic valve replacement. We'll go in a case-based scenario. So this is a 78 years old lady, diabetic, hypertensive, history of atrial fibrillation, suffered stroke 3 years back. Now she's coming with angina and dyspnea on exertion. On ECG, there is an intraventricular conduction disturbance. 2D echo shows 25% ejection fraction, severe aortic stenosis, velocity of 4.1 meter per second. CAG shows insignificant coronary artery disease. Creatinine is 2.9. Now, if we just understand, if this lady comes to a surgeon, then the STS risk score is 11.2%. Chances of her dying in the perioperative period is around double digit, 11.2. Logistic Euro score, which combines mortality plus morbidity, maybe in terms of ventilation requirement, dialysis requirement, prolonged ICU stays 44.8%. Why we are discussing this thing? Because we are having a rising life expectancy. When India got independent, the life expectancy at birth was around 35, 37 years. People used to have 6 kids, 7 kids. Despite that, India population was 35 crore. Now with 2 kids, the population is 140 crore because we don't see anybody dying so commonly because of diarrhea, malaria, and we have already achieved our triumph over coronary artery disease. A patient comes to hospital in time. So people are getting older and older, and with increasing life expectancy, the prevalence of degenerative disease like aortic stenosis keeps on increasing. If you just see the numbers, the prevalence of aortic stenosis in the 6th decade is 0.2%. Decade after that becomes 1.3%. In patients among 70 to 79, 30.9% patients are having aortic stenosis. And amongst octogenarians, every 10th person is having severe aortic stenosis. As everybody knows, in aortic stenosis, once patient becomes symptomatic, medical management has no role to play. Only way is to replace the valve. That's how the patient becomes better. Survival from symptom onset is around 50% at 2 years and 20% at 5 years. Now that's a very morbid disease, and there is steep downfall once the patient becomes symptomatic. If you go to international data, if the octogenarian patient goes for AVR, nearly 13% mortality for pure AVR, 24% mortality for AVR plus CABG. Morbidity is 60%. But at the same time, even in octogenarian, if valve is replaced successfully, 81% patient feels little or no disability, 98.3% feels less disabled, and they are reassured to go back to their normal life. So if you replace the aortic valve in any patient, they live the life as good as their counterpart of the same age without aortic stenosis. So now this increasing life expectancy, elderly and sick patient scenario came to the Western population far before we had. So Dr. Anderson hypothesized, he's from Aarhus, Denmark, where he thought that if we can stent an artery, we can put a metal stent inside the vessel. Why not to create a bigger stent, put a valve in the middle and replace the valve? It took nearly 23 years to make it original concept, and first in man was done in 2002 by Dr. Krieger. So I will not go into the details of the analysis and everything, but in a TAVI procedure, our main eyes, ear and everything is a CT scan because annulus is a very three-dimensional elliptical structure. So having a 2D understanding on an echo is very limited and doesn't give a full idea. CT gives you much more idea about the anatomy in terms of different structure. There is annulus, STJ, LVOT, sinuses, coronary heights, etc. Not only that, it gives you a very clear idea about the femorals, which is the most common procedure. If we are doing a TAVI, we have to remember very clearly the advantage of TAVI over surgery is proven only if it is done in a transfemoral route. Once this information is done, the procedure is far too simple. You just cross the aortic valve, get your valve across, keep the one pigtail right here at the level of aortic valve, and the other pigtail is, okay, this is going very fast. Yeah, somewhere here. Fine. You can see one pigtail in the aortic root, another in the valve. You just dilate the valve, you just go in, and this valve is replaced just like that. Procedure hardly takes 45 to 60 minutes. If you see inoperable patient, TAVI is far more superior as compared to the standard medical therapy, which is practically medicines or nothing. Intermediate risk patients also, TAVI is known inferior to surgery. So the results in terms of outcome in terms of durability is as good as surgery. Only the mode of replacement of the valve is different. Who is the ideal case? Those who are elderly with a previous history of cardiac surgery or radiation, or other comorbidities like liver dysfunction, renal dysfunction, previous stroke, by severe LV dysfunction, COPD. Now with TAVI is in Gujarat since last 5-6 years. We are coming across some queries that this patient has a bicuspid aortic valve. Is he a good candidate for TAVI or not? So indeed, bicuspid aortic valve is a different pendula box. You can have a simple anatomy with little bit bicuspid effect, or you can have a really nasty bicuspid valve. So we have to identify which one is a simple bicuspid and which is a sinistral one. Like in this patient, as you can see here, there is a small raphe at this point. Okay, this moving en masse. Yeah, there's a small raphe right here, as you can see on the non-side in the first image in the nearly 2 o'clock position. Other part of anatomy is good. Intercommissural distance, where the narrowest part is usually is bigger than the annulus. Don't worry, just treat this patient like a regular tricuspid valve. Align your valve, position your valve, inflate it, and come out. That's it. In a type 0 bicuspid, the situation is a bit different. You don't have a 3 cusp, so you cannot reliably align the anatomy. So what happens once you go across, instead of aligning the anatomy, you align the valve, make the valve looking straight, remove the parallax like we have done it right here. Then the procedure is essentially the same. Inflate the balloon, go up, and your job is done. Yeah, sorry. The end diagram. No, sir. It was a mistake. I have to justify 20 minutes. I understand it's been painful thing to go for, but I accidentally pressed this T. I'll just go quickly. Oh my. Yeah. I'm going to take enough time. I've traveled from Ahmedabad, so I'm not going to finish so fast. Okay. So I'll quickly go through this. Okay, we are here. So now if we come to this case, we see the different situation. In this case, the raphe right here, as you can see in the second image, at a 12 o'clock position, big calcified raphe. This can push the valve on the other side. Again, we had a difficulty in crossing the valve, so dilatation with a bigger balloon. If you have a difficulty in getting the balloon across, you can use flex-unflex mechanism, use a stiffer wire or a buddy wire or a buddy balloon. Go in, position, confirm it, and then just check the result. Because this patient had a bad raphe, you can see the valve expansion is not symmetrical like with in earlier cases. But you have to understand, you don't need to go very aggressively every time. Like in this patient, this was a type 2 bicuspid which had 2 raphe. As you can see here, one at around 2 o'clock position and one at 10 o'clock position. A little bit fallacies and analysis can show that your coronary can be a good height to coronary a low height. So we have to be very careful in analyzing the CT scan. In this procedure, we did a coronary artery protection. Okay, this is gone. Somehow it's not doesn't play. Okay, yeah. So we decided to use a coronary artery protection while doing a TAVI. This case was done in Nairobi, Kenya. So we crossed the valve, put a stiff wire. As you can see, there is a coronary stent here for a protection in case the coronary gets occluded by the previous leaflets. Getting the valve across, position it, inflate the valve, so this was the era when we didn't have accurate neo2 by Boston. So this is a very good valve for our low coronaries. In this case, as you can see, the wire and everything is above the valve. So there is no coronary obstruction. We remove the protection. Everything looks okay. But now we have a dedicated valve for a low coronary situation that's accurate neo2 by Boston. So as we know that I was just discussing in a South Asian patients, we have a higher prevalence of complex bicuspid anatomies, low coronaries, and shallow sinuses, which leads to chances of coronary obstruction. So this is a situation of 84 years old lady, aortic valve area 0.6, LV hypertrophy, normal ejection fraction. Femorals were looking good. Now, if this patient had a shallow sinus, so we did a coronary protection, put a stent into the LAD, our stiff wire across. So this is a different valve which opens from top to bottom deployment. We position it, upper crown opens. This upper crown can push the leaflet down and out instead of just pushing out with the other valves. So the low coronary situations are handled far better. As you can see, the leaflet has been pushed down below the level of coronaries, valve is deployed, and patient goes home without coronary protection, without chimney stenting, because chimney stenting is the stenting what we do from the valve from the os of the coronary. We don't know the long-term results of this thing, so I always prefer to use accurate neo2 valve when I'm dealing in low coronary and shallow sinus situation. This is a severe annulus and LVOT calcium, because sometimes a surgeons or a cardiologist sees there is a big chunk of calcium in the valve or annulus or LVOT. This creates a special situation. You try to use as you can see in the first image, at like around 7 o'clock and 4 o'clock, there is a chunk of calcium at the level of annulus. If you are using a balloon expandable valve in this position, there is a higher chances that you might injure the annulus or LVOT. So we avoid using that valve. We again use a self-expanding valve. It does not put any active forces on the structures. Pre-dilatation, again valve coming in, upper crown deployed, the position acceptable, and we release the valve. Post-dilatation with a smaller balloon to avoid the injury is the final result. So even the LVOT and annulus calcification carries a bit of risk of paravalvular leak, which is now very rare to see, because this majority of valves are available with the external skirt, which prevents the leak during the diastole. We also come across the situation of a valve-in-valve situation. And valve-in-valve is a unique situation. If the surgeon has put a 19 or 21 millimeter valve, the true ID is going to be 17 or 19 millimeter. So like 2 or 3 millimeter of the area is consumed by the stent frame and everything. And as we know in the Bernoulli equation, your resistance in the vessel behaves as per the narrowest point. So there is a far more higher jump into the gradients with a valve-in-valve situation. And if there is a severe patient processes mismatch, the mortality at 5 years approaches nearly 80% against the no significant or moderate or a mild patient processes mismatch. So in such situation, we use a self-expanding supraannular valve. This is a Medtronic Evolute R valve, just got across the previous surgical valve. We started to deploy gradually. We keep our position. As you can see this in the last image, the valve is deployed completely, and there is no PVL, no gradient. Many patients we come across where there is a bad peripheral access, like very bad, these narrowed and calcified femorals and subclavian. We can also do TAVI while we go from IVC. From IVC, we puncture the aorta, we go inside, finish our TAVI procedure, and come back out with closing the defect with the help of device. The principle is that the retroperitoneal pressure is higher than the venous pressure. So if you connect the IVC and aorta with a bridge, this acts like a bridge for the blood. It doesn't go into the retroperitoneum. So this is a CT scan of this patient. You can see how bad and calcified the aorta is. But still we could find one nice calcium-free spot on a fluoroscopy. This is how we do it. We go from the IVC, puncture, we go up.
Hello.
Get graded dilatation, increase the support using the Confianza wire and our Navicross catheter. Put a stiff wire, finish your TAVI as usual. And while we come out, we'd use this PDA device to connect aorta and IVC and close the aortic end of the puncture. We release that. We align the device with the help of balloon, so there is more opposed to the wall, create kind of hemostatic situation by tamponade. And once it is done, you can see in this image, there is no any flow going outside this thing. There is flow only from the device which is going into the IVC. So even with a very hostile accesses, we can also use the very alternative access to finish the procedure. One more interesting case of electrocautery I will show you. We have seen across, a lot of patients are coming with a prosthetic mitral valve, a biological valve which is getting degenerated. This patient does not need to undergo repeat surgery anymore. We can simply replace the valve with the help of the new balloon expandable valve, which can be deployed transeptally. This is a case where the previous leaflet were likely to cause the obstruction of LVOT. Like here we can see that we have put a virtual valve, and after virtual valve, the remaining area in LVOT is hardly 1.2 centimeters square, which creates the acute LVOT obstruction. And a fixed obstruction carries a very high mortality to the tune of 50%, even if this patient is using a bailout as a surgery as a bailout. Once you are doing this lampoon procedure, you have to anticipate that after cutting the leaflet, how much area you are going to have. So this is like 194 millimeter square, which is pretty close to the threshold of 200. So we have different ways of using this LVOT obstruction and handling the LVOT obstruction. I will not go into the much details. And there are 3 ways of doing this lampoon procedure where we split the AML, the antegrade, retrograde, tip to base. So like this patient, we started transeptal puncture in inferior posterior location using a balloon. 2 catheters are going in. One is going out into the aorta, which is snared by the other way around. Now with another catheter, you use an electrocauterized wire, as you can see in this one, to perforate the leaflet. Because this leaflet was quite heavily calcified, we could not go across in that fashion. So we decided to switch from retrograde lampoon to antegrade tip to base lampoon. So we just modified the procedure. We aligned our system and everything. Here you can see we have used a tip to base and there is a flying V. We cauterized and cut this leaflet. And after cutting, you can see there is a bit of gap in this one in the middle. And in that, you can see there is an increased mobility of one of the leaflet. As you can see, there is an increased mobility here. And in the second image higher up, you can see that there is a split at somewhere which is visible at 11 o'clock position, and development of new mitral regurgitation as in the lower image. So definitely the pure stenotic valve has become regurgitant. We have indeed cut the leaflet. We use a balloon expandable valve, deploy it, come out, and just check there is no rise of gradient in LVOT. In this particular image right here, you can see there is a blood flowing through the valve frame. So even with increasing experience and our understanding of electrocautery, we are able to handle far more complicated situation, which was a very difficult to handle erstwhile. So this is a very well established procedure of a TAVR and transcatheter valve therapies. It is feasible in majority of bicuspid aortic valves and complex anatomies. Even US FDA and US conformity has approved TAVR for a low risk patient, those who need a biological valve at the aortic position. Anatomical factor and demographic factor and even patient anthropometry plays a big role. Like even in the younger patient, if there is a small annulus and with a pulpy patient like me, this surgical valve replacement carries a very high risk of patient prosthesis mismatch. TAVI is a better option which provides a better effective orifice area and gradients. Thank you very much.